And today's show is Health Talk. I'm your host, Monique Macomb, and joining me is Dr. Sam Kazziha.
Yes.
Thanks for being here.
It's my pleasure.
And Doctor is here to talk with us today about cardiovascular intervention.
That's true.
Thanks for joining us, and tell everybody a little bit about yourself and where you're located.
My name is Sam Kazziha. I'm the Chief of Cardiovascular Service Line at Henry Ford Macomb. I am a cardiologist and a vascular interventionist. That means I do plumbing of the heart and the arteries without surgery. We have 3 clinics. I run one in Washington Township, next to the Washington Township building, and then we have one in Sterling Heights and one in Barclay Circle in Rochester. Obviously, I'm affiliated with Henry Ford Macomb as my main hospital, and I have been in Southeast Michigan for more than 25 years. And I did my training at Cleveland Clinic and Royal Oak Beaumont at one point.
Well, thank you so much for being here, and we're so glad that your expertise is right here in our area.
It's my pleasure, and I'm very, very pleased to be here with you today.
So let's get started talking about cardiovascular health.
Cardiology or cardiovascular disease is #1 killer in our society, and heart attacks has been always #1 problem for most of patients, but now because we're living longer, valvular heart disease is becoming an issue, meaning that as people get older beyond the age of 80, we notice that the valves of the heart are becoming really also rusty. They don't open well. So our emphasis more in cardiology, not only on the plumbing of the arteries around the heart, but also about the valves of the heart. And for a long period of time, if somebody had a valve issue, it would have to be corrected surgically, but now we have the ability and the option of correcting this without surgery.
That's right. And that's what we're here today, is showcase that particular procedure and tell everybody the name of it.
So TAVR,
TAVR.
It's a transcutaneous valve replacement. It's really a fancy name for saying that the valve, instead of undergoing surgical intervention, instead of being under general anesthesia, instead of having your chest open and cut, now we can do this through a catheter, just like when we do angioplasty or stent for somebody who had a heart attack. This is more of an elective procedure. It's done usually from the groin. Occasionally it can be done even from the carotid. But 90% of all the procedure, we do them through a catheter going from the groin, where we can go up to the valve and fix that valve.
And this dramatically changes things as far as the time they're on the operating table, and there's no cracking, cutting of the chest, and minimized recovery time.
That's very true. So let's go through a synopsis about what is aortic valve stenosis, because really that's what we're talking about. You know, generally speaking, a patient will have, in one of the main valves of the heart, which is called the aortic valve, is really the outdoor for the heart to push the blood to the rest of the body. So if that door cannot open well, the heart is not going to be able to function or push the blood to the rest of the body. That valve is usually has 3 doors, 3 cusps. They move open and close on a regular basis since the day you're born, regularly. With time, the valve unfortunately has a tear and wear, and as we get older, there's a good bunch of us, at least 7 to 10% of patients will have what we call aortic valve stenosis. Stenosis, that means the valve after tear and wear becomes really lumpy, bumpy, and the valve does not open wide. By not opening the valve wide, the heart has to work harder and stronger. Patients are going to feel tired. Patients is going to be short of breath. Patient could have chest tightness. Patient can have a heart attack. Patient can have a heart failure. These are the symptoms we see usually around the age of 70 to 80. That's when the valve becomes acting up. For a long period of time, this valve would have been corrected surgically, meaningly, once the patient is recognized to have aortic valve stenosis, the patient would need to undergo a series of tests. The main test to evaluate the valve of the heart is by performing what we call an echocardiogram. An echocardiogram is an ultrasound. So the physician will be doing an EKG, he will listen to the heart, he said, you know, I hear a murmur, the patient's having symptoms, I'm going to do an ultrasound or echocardiogram, and that will show the valve itself. If the valve appears to be tight, then the patient would need to undergo further investigation to see whether this valve is correctable. For many years, whenever we had to do the valve, we had to do surgery for patients. The problem is a lot of our patients had already been having either bypass surgery previously, they have lung disease, they have kidney disease, they have a lot of what we call comorbidities. It puts them at very high risk to undergo general anesthesia or major heart surgery. So this was reserved really to patients who were considered to be low risk. So the high-risk patients did not have the opportunity to have this fixed, and unfortunately eventually died because of this valve disease. Well, at one point we were able to, through research and through working with pioneers such as Dr. Bill O'Neill, who is the head of the structural heart program at the Henry Ford Health System, we were able to really repair this valve through a catheter. That evolved from being done for patients who are considered to be high risk to people who are considered to be intermediate risk. Then also recently, just about 2 or 3 months ago, the FDA approved this procedure to be done to patients who are considered low risk. What does that mean? That means if a patient has a tight valve, no longer has to have surgery, have the option of having surgery versus having this without surgery.
That's a lot of good information. A lot of changes there in our system.
So that really changed the way things gets done for our patients. Number one, for the high-risk patients whom they didn't have any options at one point, now they're going to be able to have this and they can live longer and do a much better quality of life. For the low-risk patients, they're going to be able to have a choice, and that choice either by undergoing surgery or by actually inserting a valve. Now, this is really a design of the heart from the inside. This is what we call the left ventricle. This is the main pump of the heart. It's going to pump the blood through the valve. Now, if this valve is tight, again, this heart is not going to function well. And now we are able to go with a catheter and a balloon, and this balloon is going to expand this stent, which has a valve. And this valve is somewhat similar to the valve you get implanted surgically. The procedure takes about 2 hours usually, and the patient will not be under anesthesia. In fact, the patient will be awake. They will be lightly sedated. We'll be able even to talk to them, and that makes it much low risk for this patient to go this procedure. The patients usually will end up going home within 24 hours. So Henry Ford Macomb has been one of the places which recently have evolved in doing this procedure. We were very happy and pleased to have that one of the pioneers of this procedure is working with us now, Dr. O'Neill at Henry Ford Macomb, and working with multiple cardiologists to perform the procedure. Now I want to bring something very important to the public, to everybody to know that this procedure cannot be done without having a teamwork. That includes a cardiologist, interventionist, a person who does things with catheter, a surgeon. The surgeon is very important also because the surgeon is going to evaluate the patient. The surgeon is also an integral part of the procedure, will be also in the case. So you have in every case at least 2 to 3 physicians working together in symphony to really do the procedure for our patient.
Very nice. Very nice work there, working together with the Henry
That's right.
Ford Health Systems, right?
Yes.
So you touched on this a little bit before, but if someone is concerned that they have a heart problem, what should be their first step?
So the first step is if I'm lethargic, fatigued, get tired very quickly, or if I have chest discomfort or shortness of breath, I would urge the patient to be evaluated by a cardiologist. The evaluation starts by, as I said, by what we call history and physical, where the physician will ask certain questions. The patient needs to explain really what they're feeling, how often, rather than giving diagnosis, because patients tend to really kind of be in denial. And then the physician will perform the physical exam, do an EKG. And as I said, if there's something suspicious about this, part of it is to do what we call the echocardiogram, which is the ultrasound. Another one could be a stress test. And the physician is going to put all of this information together to come to a conclusion and then go from there. If the patient is determined to have aortic valve stenosis, doesn't mean that everybody needs to have a procedure. Some of them, we have what we call mild aortic valve stenosis, which is really, you know, it's rusty valve, it's opening, but it's not opening as wide as it should be, but the patient can do well. But what happens is that the patient will be monitored now on a regular basis, about twice a year, to make sure it doesn't get worse. If it does get worse, we are already prepared. Then the patient will go to phase 2, which is really having the team of physicians and nurses now studying the case to prepare him for such procedure.
Wow, so they really need to get to the doctor, so you're following their heart health through their life.
Absolutely. You don't want to wait until the last minute. You don't want to be in denial. In fact, I would urge people always to be evaluated after the age of 50 anyway for cardiovascular disease in general, because there's a lot of other problems can happen beside the valves. As we discussed, the arteries of the heart can be blocked, which is the most common thing. People can have irregular heartbeat or atrial fibrillation. People can have dizziness, syncope, palpitation, shortness of breath, heart failure. All of these, part of it could be caused by the valve. And of course, today we're talking about the valve specifically, but for the health of cardiovascular system, it's clearly have a visit after the age of 50, and then every few years, unless there is some problem, then it needs to be really checked on a regular basis.
Great. Well, let's take a short break and we'll come back and talk to people more about cardiovascular intervention.
Thank you.
We're going to take a quick break and we'll be right back.